Hi, everybody. We'll get started in just a moment. Thanks for joining us. We'll give a minute for everyone to be let in from the waiting room. Thanks for keeping yourself on mute as we have a large group on our call today. Hi, everybody. This is Libby Sagara. I'm with Blue Path Health, and I facilitate the eConsult Workgroup. We'll get started. We're letting folks in from the waiting room, so thank you for your patience. Thanks also for keeping yourself on mute. Please use the chat if you'd like to share questions or comments with us. We want to make this as interactive as possible, but we do have a large group on today. So we appreciate your patience here, and looks like we can get started. For those of you who are new to our group, we meet on a monthly basis. We have been around for about 6 years, if not more. We like to note that our group is growing every month. We're bringing in new representatives from different states, payers, providers, patient advocacy groups, and it's just great to see our group grow. If you don't know much about us, we do like to bring in best practices and publications that are bringing up the successes of eConsult from across the country. That's really the focus of our call today. We started out being fairly California focused, and since we've grown, we realized there's so many great things that are happening across the country. We want to be able to highlight those examples of how states, leadership, state agencies, and payers are really spearheading changes and embracing eConsult reimbursement and adoption. So today we're going to focus on, start out with California. We have some great news in terms of advancement of eConsult reimbursement and support at the state level from California. We will hand to Mark Carollo from state of Colorado talking about the RFP that the state's developing. And then we will feature Lisa Watkins. So Dr. Watkins is going to talk a little bit about what she's hearing from different payer representatives from across the country. So with that, I'm just going to make sure everyone's on mute. Thanks again for keeping yourself on mute. And I'm going to hand to my colleague, Robbie Franceschini, and Michelle Canales from Senator Caballero's office in California. So Robbie, go ahead.
Awesome. Hi, everyone. Good to see you all. Robbie Franceschini, also with Blue Path here. We wanted to just kick off today with a little bit of an update on SB 365 here in California, which would provide reimbursement for PCPs in California for eConsult, including FQHCs and RHCs, and also to just provide a little bit of background on some of the research we've done just around the allowance for FQHCs and RHCs to be able to be reimbursed for eConsults in California. I think I'll hand it over to Michelle first, maybe just to give us an update on the bill, and also to just a little bit of context around how this bill kind of came to be in some of the stakeholder needs around eConsult reimbursement.
Thanks, Robbie. So I will go ahead and start with how the senator got interested in eConsult and how 365 was ultimately introduced. She had heard anecdotally in the fall of last year about some FQHCs that were having trouble gaining access to services that have been approved during the state of emergency for telehealth. And these were anecdotal. We were hearing them from like small clinics. So she asked me to start doing some research into this. I met with like various stakeholders trying to figure out, were FQHCs being restricted from these telehealth expansions that were temporary, but seemingly everyone was supposed to have access to them. And my meetings led me to connected me to Blue Path Health, and we started looking into like a bigger picture of what are FQHCs and RHCs restricted from regularly. There apparently are a lot of telehealth services that don't get extended to them. So Senator was really interested in this. She represents a very rural part of California. It's the Central Valley. So for anyone who's familiar, that's Fresno, Madera, Merced, the Salinas Valley. In her district, it's really hard to get around. Transportation is a huge issue. And then health access is a really big issue. Your local clinic, if you live in, some parts of the district, might be an hour away. And then specialty care might be non-existent in your whole county. There are patients who have to drive hours to see a specialist. So health access has been a really big issue for her. But of course, with COVID, she was really interested in telehealth expansions. So meeting with Blue Path Health, we looked, I learned a lot about e-consults, and it kind of sounded like the solution that my boss was looking for. Right, currently the specialist provider is able to reimburse for an e-consult between the two physicians, but the physician at the originating site, who's usually the primary care provider, cannot be reimbursed for that. So, despite all of the time and effort that the primary care provider is putting into the e-consult, whether it be like ordering labs or, multiple meetings with the patient, none of that is reimbursed. So the idea to reimburse, that side of the e-consult equation just kind of made sense. And then we wanted to include FQHCs and RHCs as well, because these clinics are seeing, really the most vulnerable patients. And the wait lists for a simple referral could be, months for some specialty providers. So we introduced SB 365, and very early on, we met with a lot of stakeholders. That was pretty key to try to gain support. We did manage to get a very good list, which helps, when you're moving through the committee process, just to have a large support behind you. Additionally, one of the things that we did really early on that we knew would be vital to the bill's success is we met with the Department of Healthcare Services. We had to figure out, what their position was on the idea of expanding to PCPs, but also to FQs and RHCs. And given, the last year, this was all around February or March, we thought they'd be probably in a more sympathetic position to expansion. The meeting with the department rendered a little bit of a hiccup for us. They were under the impression that CMS would not approve e-consult reimbursement for FQHCs and RHCs. They said they had had previous discussions with CMS, and that was something that they didn't think California would get federal approval for. So from that point on, the Blue Path Health, they've been the sponsors of the bill, but really just so instrumental in navigating this kind of new area for our office, but also for the state, it seems. And Robbie will get into like the research that he's done in a little bit for how we countered the department's position. But before he does, I'll just kind of mention, where we are now. In response to the department's position, we did take an amendment to make the bill contingent on CMS approval. And we did this as kind of a strategic move because we were in the appropriations committee at that time, and the department, it's very possible that they could have, swayed the direction of that bill to be held in a fiscal committee based on their position. So we took it as a strategic move, but also because we feel very strongly that there is a way around this at the federal level. that Robbie can get into in a little bit. So we did get out of appropriations. We got out of the Senate, and now we're in the second house, which is really great. We are in Assembly Health and almost done through the legislative process. The hearing will be next week, and we feel like the bill is in a really great position to hopefully pass and make a really good change. I don't think I have to preach to anybody on the call the benefits of e-consults, but for the senator's district and her perspective, this is going to just help patients, get better connected. It will determine whether or not a referral to a specialist is actually needed, and that will help with specialists. It'll make appointments more appropriate, and if a concern can be resolved through the e-consult with the PCP, then that's kind of better for everybody. So that is the state of things now, and then Robbie can give a lot more information as to our rebuttal to the department and a way around this kind of CMS block that they put up.
Awesome, thanks, Michelle. So yeah, one thing we wanted to do was just share out some of our findings from the past few months of really doing some research, and many thanks especially to the California Primary Care Association and their colleagues at the National Association of Community Health Centers for really providing a lot of technical assistance in this effort to really understand how FQHCs and RHCs can get paid for e-consult. And additionally to Rafael Gomez, who did some work with the California Healthcare Foundation that was also really helpful in this effort as well. And just additionally, just to note too that, we don't intend for anything in here to be legal advice. And we know too that in many states, often different interpretations of the regulations are made and by both CMS and state agencies. But really, we wanted to share out some of the research we found and shared back with the Department of Healthcare Services. I think the first question we had was, what is a visit or an encounter, and how does e-consult fit within that definition? California really uses the same definition of a visit for FQHC, RHC reimbursement that Medicare does, which does state that it has to be a face-to-face encounter between a patient and one of the enumerated providers. Subsequent state plan amendments and waivers in California do allow for FQHCs in certain instances to waive the face-to-face requirement and be able to receive reimbursement. And we know too, this is really the basis of the prospective payment system for FQHCs and RHCs. So to that end, we really zeroed in on the fact that, e-consults really aren't considered an encounter because the provider never sees the patient. So really, pointing to the Medi-Cal definition of an e-consult as that asynchronous consultation service. And really thinking of e-consult in a community health center context really as a supplemental service, if you will, to an encounter between a provider and a patient to some extent. If we move to the next slide, additionally, another question we had was, okay, if an e-consult's not an encounter, how can you pay for it? So I think as many on this call are probably familiar, given this new world we're in with telehealth and trying to figure out how to reimburse community health centers for telehealth post-pandemic, there is an allowance for an alternative payment methodology under the Social Security Act for FQHCs and RHCs. It must be consistent with the, efficiency, economy, and quality of care, and ensure, to the extent possible that, care and services are available to that population in that area. So to that end, states aren't necessarily restricted from making additional payments to reimburse for the additional cost of e-consult, and aren't necessarily barred from drawing down their federal match dollars to do so either. Another place we pointed to was the CMS telehealth toolkit that came out last fall and was updated earlier this year, really signaling to states that they have broad flexibility to cover telehealth through Medicaid, And for example, they do point out in a footnote that consultations between professionals in eConsult can be available when those costs are incorporated into the rate that the state pays providers for a covered service. Additionally, to be able to adopt an APM, a state does have to go through this state plan amendment process and receive approval from a CMS. To our knowledge, no state has sought a spot, specifically just for eConsult at this moment in time. To one corollary we kind of pointed to in our work was really Ohio and their work around paying for remote patient monitoring for FQHCs and RHCs and creating a separate fee schedule for RPM for those clinic providers. And thinking of that as potentially the model for eConsult to take in California and being able to pay FQHCs and RHCs on a separate fee schedule for eConsults outside of PPS. So just moving to the last slide we have, we thought it might be helpful to just share some key considerations for others that I think we've learned through this process. I think number one is consult your state primary care association. They are really the experts when it comes to FQHCs and RHCs and have a wealth of information on what the law is in regard to a payment for FQHCs and RHCs and kind of the state of play of things. I think another, and this points to Michelle's comments at the beginning, understanding the full extent of eConsult within your state's community health centers, and where and why there's a need for reimbursement for these providers. Additionally, thinking about the timing, the time could be ripe in a lot of states beyond California to think about paying for eConsults, whether that's for FQHCs and RHCs or other providers too, as we move into this post-pandemic world and states are re-examining their telehealth policies. That is a good time to also think about how eConsult really can be wrapped within those larger policy changes. And additionally, thinking about how eConsult can be wrapped into a larger APM. I know in many states that, not just California, they're considering alternative payment methodologies kind of writ large for FQHCs and RHCs. So thinking about how eConsult can play a role in those as well. And then lastly, also to Michelle's point earlier, engage key stakeholders in your work. And I think as we found through this work, eConsult really stands to benefit not just patients and providers, but also your Medicaid managed care plans as well. So it's really one of those areas where kind of a lot of stakeholders can coalesce around the same issue and support it and push it forward. So really thinking carefully and kind of widely about the different trade associations and stakeholder types that you can bring in to support your work around this. I see a couple questions came in. What would the reimbursement rate be for PCPs and how would it be determined under SB 365? I think that's a good question. I think it would be up to the Department of Healthcare Services ultimately to determine the reimbursement rate. I know for the specialty code or the remote consultant code 99451 in California, it's a little bit lower than the Medicare rate and is about $31 right now. But that was one thing I think in talking with folks that we thought should be kind of left to the department to kind of ultimately determine what the actual rate would be. And Greg, would you like to share your question with us as well?
Sure, thanks, Robbie. So the state, and on the request of CMS, is now allowing in lieu of services where a service could be provided that's not a conventional Medicaid service. And we see it now in California with housing services, medically tailored meals, sobering centers, recuperative care centers. But it seems like eConsult, with the acknowledgement that it is likely to decrease overall costs, which is one of the bases for in lieu of services, that it's something that could be approved by a state and provided, and would allow the Medi-Cal managed or the Medicaid managed care plan the flexibility to pay for the primary care provider as an in lieu of service in order to get these services provided and lower overall costs.
Yeah, I think that's a great kind of creative idea, especially if the state should SB 365 or similar kind of efforts in other states not come to pass. That's actually probably a great idea for managed care plans to be able to figure out a mechanism for reimbursement for e-consult, and also good timing here in California too, since in lieu of services really kicks off next year.
Thank you, Robbie and Michelle. Go ahead.
Oh, I was just going to say if there are any other questions. I see just one comment too around the rate, and the perception is that the cost of a telehealth visit is less than a face-to-face is incorrect. Yeah, I think there are definitely a lot of conversations right now in California regarding Medi-Cal reimbursement for telehealth, I think writ large, and those modalities that have face-to-face equivalents. And I think the negotiations are still going on, and it looks like ultimate determination may be punted a year or two down the road for Medi-Cal in terms of engaging stakeholders in that work. So I think figuring out the rate to pay for telehealth, certainly the conversation's not over yet when it comes to that piece of the work too.
Thank you, Sean, for bringing up that comment. And thank you so much, Robbie and Michelle, for your thought around this and the work that it's taken to really educate at the state level of what's needed in terms of primary care provider support. And thank you, Dr. Buchert. Dr. Buchert is our clinical advisor. So thanks for your time, everyone. And with that, I'm going to hand off to Mark Carollo, who is with the state of Colorado. And I think it was great to land on what other states might be thinking. And of course, we have different approaches, and the support that's being shown in Colorado is so innovative in looking at a statewide RFP. So Mark, I'll hand off to you to talk about what's happening in Colorado.
Thanks, Libby. My name is Mark Carello, and I work in our delivery system and payment innovation section. Libby, if you can go to the next slide. So I don't know that I'll spend too much time here, but we've been talking about e-consults in Colorado for quite a while. We have a unique or a non-traditional sort of managed care arrangement. We started in 2011 with more of an accountable care organization model that really focused on medical home models of care. So it's really a managed fee-for-service focused on primary care services. We re-procured that program in 2018 for our phase 2, and we retained that sort of same model as a managed fee-for-service on physical health side, and then we combined it with our capitated behavioral health benefit. So we have more traditional managed care for behavioral health, but our physical health is fee-for-service. During the first phase, some of our managed care entities did come to us with e-consult as a potential solution to really support primary care. And we were able to receive a small amount of funding from the state legislature to do a pilot, which we probably was not our most successful pilot. We tried to use our health information exchange that didn't have a complete sort of match for an e-consult program. So we did it with just one specialty care and a few primary care practices. And so, you know, we learned some important things. It wasn't the right fit at that time. And there were other initiatives moving at that same time. We had a state innovation model funded by CMS, and they funded a couple larger institutions to start planning. So the University of Colorado School of Medicine got one of those grants and really looked at how to do e-consults in their system and potentially to broaden that. And since 2018, with the second phase of the Accountable Care Collaborative, our governor's office has really focused on healthcare initiatives, telehealth initiatives, and really focused on saving people money in healthcare. One of the initiatives the department has been funding directly, the the University of Colorado School of Medicine to, through some funds that we give them, really pushed them on implementing an e-consult program. And they have been expanding that primarily within their network, but they've been slowly building connections with some of the FQHCs to support those programs. We also know that Kaiser here in Colorado, as part of their community benefit, has established relationships with some FQHCs as well. So there are a number of different programs going on, smaller, and I would say sort of that slow growth of e-consults. With COVID last year and our governor's focus on telehealth and healthcare cost containment, there was one of our wildly important goals from the governor's health cabinet was to establish the foundation for e-consults in Colorado to support PCP care and reduce avoidable specialist utilization. So the department really took lead on that as part of our larger telemedicine initiatives in as everyone is doing with COVID, sort of exploring that. And so we put together a budget.
You've been muted, Mark. Can you unmute yourself?
I am so sorry. Did you hear any of that?
Back. We just missed about 10 seconds, Mark. Go ahead.
Oh, I have no idea how it got muted then. So,
okay.
Just said our budget request was approved and funding was approved in May. So on July 1st, we will have funds to really implement the department's e-consult program. Next slide, please. I'll say one of our focus in Colorado, as I said, we've got these smaller initiatives going on with CU and Kaiser, sort of working slowly to connect with other practices. We want to have a statewide program. We think it's essential. We want to make sure that those smaller practices in rural and frontier areas receive the benefit of e-consult. We think those are the practices that really need e-consult because they have less access than those in the Denver metro region. So, so that has been sort of a driving concept of ours, is how do we create functionality across the whole state and make it accessible to everyone. So our budget request was really to create a statewide platform for Medicaid e-consults to reduce duplicative or unnecessary specialty care expenses, improve access to timely specialized clinical guidance. And we also want to search for a solution to help efficiently triage members to specialists when such care is medically appropriate. Next slide, please. So as I said, we want a statewide program, sort of web-based, as easily accessible to primary care, sort of single sign-on, all of those sort of functionality, maybe even be able to be accessed from a phone, but to have it broadly accessible to all of our primary care medical providers, our medical homes in the state. We also want to leverage our Medicaid enrolled specialists. So I know some e-consult systems currently have national networks. We really want to focus on using the Colorado providers, partly because when a member does need to be seen, we want to make that easier for those primary care providers who have engaged in an e-consult, for them to be able to get a member actually seen by a provider in Colorado. As part of our budget request, we did include sort of both the costs for implementing an actual e-consult vendor in the state, as well as our benefit reimbursement. And so the budget office looked at payment in Connecticut and Medicare rates, and proposed budget of we'll be reimbursing both the PCMP and the specialists. And the PCMP reimbursement is $17.34 as proposed in the budget, and the specialist reimbursement at $35. No, that's a common question. We are really focused on our Medicaid fee-for-service physical health. I know there's a lot of focus on behavioral health, and there's a need to do that. It becomes a little bit more complicated when we have a capitated behavioral health program. So it's something we definitely want to explore, and we will work with our managed care entities to see how they might be able to partner with the statewide e-consult vendor and figure out a payment arrangement to cover some of the behavioral health consults as well. But we are really focused on the Medicaid fee-for-service physical health. What I would say is what started a lot of the e-consult, cardiology, endocrinology, things like that. PCMP is our primary care medical providers. That's our medical homes. So they are contracted with our managed care entities to sort of serve as that focal point of care for our members. And we have a mandatory program where all members are automatically attributed to both a primary care medical provider and to our what we call our regional accountable entities. Those are our managed care entities. We are starting, our budget request really was as a cost savings initiative. So we used the available research to sort of ascertain where we think we can save money for the state and for the Medicaid program. So we're really focused on addressing acute care needs for those members that don't have an established specialty care relationship. We have been getting a number of questions that people would like an e-consult system to provide that ongoing care coordination, care management. We really want to focus our payment on those members who don't have any specialty care. So that's how we are designing our benefit for e-consult reimbursement. We are exploring a phased rollout approach. We'll probably start with 4 or 5 specialty areas. When we roll out, we're trying to do this relatively quickly, although as a state and state procurement and federal regulations, it never seems to happen very quickly, but we will start with 4 or 5 specialty areas and then continue to grow that and sort of expand this, the primary care providers that are participating in the program. The other thing we want to really explore with vendors as we put out our request for proposal is how to support referrals. Right now, primary care providers and members just go to the department's provider directory, and we hear lots of times that people just spend so much time calling different specialists and being told no, they can't be seen. So we really want to figure out with our e-consult vendor, since they'll be working with a variety of specialists, how to identify those that actually are willing to see Medicaid members and have some capacity and be able to provide that information to those PCPs when a member actually needs to have a face-to-face visit. And then we'll do standard reporting. And then as part of our budget request, we requested some additional funds to really do a cost savings evaluation, really dive into that. How do we determine that we are saving funds and that we're reducing avoidable specialty care visits? We know that that's a fairly complex analysis and can't necessarily always be done with just claims-based, which is what we tend to use in Medicaid. So we want to sort of design that evaluation and then sort of be able to move that forward after sort of 2 years of sort of designing that methodology. And then the department would sort of take over that methodology and be using that moving forward. So next slide, please. So some of the things that we've just been challenges that we're sort of struggling with and thinking through a lot, and we're hearing from various places, how do we want to set up a statewide platform. We think it's essential for that. We also know other payers are starting to pay for e-consults. So how do we collaborate? We've done a number of multi-payer initiatives here in Colorado. They often take a long time. So we've been wanting to move this forward, but we are trying to design our request for proposals in such a way that it can be a platform that other payers can sign on to and join. We're also trying to figure out that transition with those programs that are currently working with, our CU program, the Kaiser program, how to not interrupt that, but how to easily transition to this broader statewide program. So we're starting to meet with them and really think through what that change process was, because we want all of those, our larger practices and networks to participate in eConsult in the statewide platform. So how to make it as easy for them as possible. And that is one of the things we also included in our budget request, is to build that interconnectivity to some of those large practices so that it will be easier for those specialists to participate and not have multiple sign-ins. And then, as I mentioned briefly, we're just trying to figure out what is that right level of support for referral functionality that would be helpful. We don't have enough funds for a full sort of referral system for all specialists and actually have the system do the scheduling of appointments. But what can we do that is better than we currently have and provide some better information to our primary care providers and members? And then next slide, please. So we are currently continuing stakeholder engagement, trying to finalize the RFP. And with our budget request, we received some staff resources. So we are staffing up our program. One of the things that we are doing that may delay our timeline a little bit, but we think it will be worth it, is we have started conversations with CMS for enhanced funding for the program. Currently, we're around 55% match in Colorado. As part of, we see this the eConsult system connected to our MMIS system, which then makes it make it eligible for an enhanced 75% or 90% match, which would go a long way towards cost savings. So we are just beginning those conversations. We don't know how that will go, but we will be sure to sort of provide updates as we learn more about that. But that is a conversation that we are starting. It does add some extension to our timeline. They need to review our RFP before it actually gets posted. They'll need to review our final contracts before we can execute. So there are some things there, but we are hoping to post our request for proposal by the end of this summer. And then in the fall, we will select our vendor and work on executing that contract. And then so early of 2022, ideally have a contract executed and then have probably 3 to 4 months of implementation, really building the system, connecting with our MMIS, recruiting providers, training them. And then hopefully in spring 2022, we can go live with our eConsult program. So I know there are lots of questions and I wasn't tracking them.
Yeah, no problem. The first question is from Diana Camacho from California Healthcare Foundation. Do these reimbursement levels you mentioned, which are PCMP $17.34, specialist $35, do they apply to federally qualified health centers and rural health centers also?
So the previous presentation raised some good questions for me. Our recent conversations are that we probably would not it would not apply to our FQHCs and rural health centers because of the cost-based payment arrangements that we already have with them, that it's sort of factored into their current costs. But I think we have some things to rethink and relook at based on some of the analysis that was presented earlier, and there may be some ways to incorporate that into their cost rate setting.
And that's why it's great to work together to share your examples and and hear what's happening in other states. So thank you, Mark. Yep. One comment from Dee Dee, who's also in Colorado. The scope of the problem is that 486,000 Medicaid members forego needed specialty care appointments annually. And it's great to have Mile High join us. Thank you, Dee Dee. Dr. Gibney, do you want to unmute yourself and share your comment here?
Sure. So I really think that you are on to a great approach here, Mark. You mentioned that you're going to start with a few key specialties that you think are going to be the highest value. Our experience taught us that after our primary care providers had such a great experience with the first couple specialties, I started getting calls and emails asking when we were going to add more specialties, and when does ortho go on, or when does nephrology go on. And And so if you guys achieve your goals in this first go round and you are successful with those first 4 or 5 specialties, I have no doubt that you will experience a lot of demand for additional specialties, and that may, kind of spur the next round or the next phase 2 of whatever you're doing. So I'm really encouraged and excited about what you've got going.
Thank you. Yeah, I'm aware of that. We have had a lot of internal conversations of, do we try and open it up broadly? I think it's mostly, we want to get a system up soon, and the ability to train and ensure that all the specialty areas know how to effectively use the system. So I think that's probably more of our limit right now, is just, let's try and get something up so we have, something's better than nothing, and then pretty rapidly add new specialty areas as we work with the vendor to train new provider groups, new primary care practices, and everyone to get on board to the system. So, so that's more of our thinking, but I appreciate that.
Thank you so much, Mark. This has been so helpful to hear the process, and we look forward to working together and sharing these examples as you progress through your timeline. And with that, we're going to pass over to Dr. Watkins, who will share some payer perspectives of her research from across the country. As we know, we have great Medicaid engagement. We'd love to hear other payers' perspectives too. So go ahead, Dr. Watkins.
Great, thank you for this opportunity. This is really a fascinating discussion. As Libby mentioned, I'm a physician. I'm actually a pediatrician by training and practice here in Vermont. And I currently work with the Middleburg Memorial Fund, which is an endowed operating foundation of over 100 years in age that works to improve population health by connecting leaders and decision makers with the best available evidence and experience. Next slide, please. So as my particular body of work with the fund is specifically in support of multi-payer primary care transformation. And I run a network that is indeed nationwide, where we share experience, information, and best practices. We have largely been focused on efforts that have involved the Innovation Center at CMS, but really working at the regional level and supporting the individuals, specifically payers, not as much providers directly. So we have various activities, virtual, telephonic. In the before times, we had in-person meetings, and we look forward to those in the future. Next slide, please. Underlying assumptions, which I think I can safely say are probably shared with this group, is that reform primary care is essential to a high-performing healthcare system and can improve the health of populations. And to achieve those goals, you really need to align actions across multiple payers. So some of what you'll be hearing from me today is about commercial plans, some for profit, some not for profit, and the information that we've gathered about their activities regarding e-consults. Next slide, please. This is just a quick timeline. These are the particular activities that we've been involved in over the last 13 years, it looks like. Initially a group of Northern New England and then all of New England states that were involved in multi-payer primary care transformation efforts, joining in partnership with the federal government through the multi-payer advanced primary care practice demonstration, which ended in 2016. And the fund has continued its support of the comprehensive primary care initiatives and moving forward into primary care first. Next slide, please. So as part of our work, we collaborate with other sister foundations, and we are currently engaged in a partnership between the Innovation Center at CMS, Arkansas Blue Cross Blue Shield, which has been a very active member of my network, and the Peterson Center on Healthcare. And we're supporting practices to enhance care coordination between primary care and specialty care. And this is obviously focused on providing access to e-consults. I think you may have probably heard from Julia Murphy at the Peterson Center. She and I are partners in this work, and I'm really an advisor to her. She's doing the heavy lift. The goal of this 2-year pilot is to assess if implementing e-consults can lower costs and enhance the quality of care, specifically in a commercial payer that is regional in nature. And it's a unique partnership. The reason Julia brought me in is that because of my relationships with multiple payers around the country, it helps her to get some sense of the landscape. Next slide, please. So what we did was an informal survey of a group of CPC plus payers, otherwise known as some of my friends, who I work with and have worked with now for several years. And essentially we asked the question, does your organization have the eConsult codes turned on? It was a smattering of payers in several regions. Two of the payers we had were national and with a very big footprint across the country. We had a couple of regional payers in the Midwest, several in the Northeast, and one in the upper Midwest. And this was the answer to that question. Do you have your codes turned on? We had two out of the two national payers indeed did. None of the regional payers that was involved in more than one market. There's only one that we were asked did. And then 4 of the 6 community or state-based plans did. When we were asked them as part of the survey if they were not currently using the codes, if they would be interested in learning more about the outcomes of the study, we got a great deal of interest, and people followed up to make sure that they would be circled back with. Next slide, please. And then another question was asked, like, what are you doing when you're implementing your eConsult codes? Are you actually doing it for all your product lines? And this was the spread. So the commercial, obviously, well, you can just read this slide yourself, you can see. So there was a sort of a variety of how the codes are being implemented. And I think that's probably the last slide, Libby. I believe that's the end.
Yes, and Dr. Watkins, I was gonna type in this question, but I can just ask you, when you spoke with the payers, was there a trend in terms of codes that they were using? Was it typically 99451, 99452, and 99445, 99446 through 9, or did you hear just a smattering of codes?
Well, let me be so glad that I have the survey open. So the specific question was 99451 and 99452, asking if they were turned on.
Great, helpful, thank you. We welcome questions for Dr. Watkins. I have a couple of questions for you. Do you know, when in your conversations with commercial payers, is there anything we should be thinking about? You know, we've been very focused on Medicaid and access over time, but there are obviously key cost savings that we can convey to commercial payers. Is there a message that you might suggest we share with those who are interested in eConsult?
So I think it's actually a very similar line of reasoning, that this clearly provides access to specialists that otherwise would be not as available or certainly accessible. So I think that the same sort of higher good is really part of this. And especially, I realize that when the payers that I deal with are those that have already made a commitment to innovation through their work with the Innovation Center at CMS. So I think it's sort of, there's a preaching to the choir part of this that may skew the answers that you get. But I think it's very important to talk about how this really does support primary care. And the more that they can do things in concert with each other, the easier it is for primary care to do their jobs. And that just increases access overall.
That's so helpful. I like the point around education, especially in past conversations. At times we've heard, if there is not a problem in access, let's just say you have adequate access in your county or your region or your state. What would you respond if you know of a specialty that's not an issue for a commercial payer? What would the value be, or what can we share with commercial payers when access is not the number one challenge?
I think equity is a challenge, actually. So overall access, and you're talking about rural communities versus urban, where there's more density of specialists, but frankly, it's fairness, and you're talking about people who for patients to have a suite of options. I think that's a very reasonable goal to have.
Thank you so much, Dr. Watkins. It's going to be great to hear how Arkansas moves forward. We know they're early in their process, but when we hear different examples, it's wonderful to compare. We hear a lot of urban examples from California, but we also have some very large rural regions that are launching eConsult. Colorado has both too, and it's going to be very helpful to have another example of what's happening in Arkansas. A couple of questions have come in. Go ahead.
To engage payers in this effort. I mean, they have a very active and effective multi-payer regional table, as it were. So there's our ongoing conversations to try to link arms with the other payers and to do some of this work together.
Definitely. And Julia is an active participant in our work group. She couldn't join today, but she thanks you for your contributions. So a couple questions for you. How many payers were involved in the survey?
I think we surveyed a total of maybe 12, and I think I got 9 answers.
Great. And then last question is, what % of them were CPC plus payers?
They were all CPC plus payers.
Oh, great. Thank you so much. Well, we hope that you can remain involved. Dr. Watkins, we'd love to hear your learnings as you and hear more about your group and your work across the country. It's helpful to have the commercial perspective as our work across California encompasses not just Medicaid, but patients under all different lines of business. So thanks so much.
Sure, you're quite welcome.
We do welcome additional questions that might come through. If we don't have time to answer them today, we can share them with Dr. Watkins offline. So thanks again. We have a couple of news items to share with you before we wrap up today. We, as an eConsult work group, like to focus on specific challenges we're hearing about in the field. So if we hear of regions or of news that highlights a specific access challenge, we really want to hone in on how we might address this as a work group. So as you can see on my screen here, in California and of course across the country, we're facing a challenge in terms of medication management, pain management, and a shortage of providers, as you all know. So what came out recently in California is with closure of a large pain management center in Central California, many patients were left without access to care. So what we have done in collaboration with ConfirmEd and with the Central Valley eConsult Coalition is to set up CME. So this is open to all providers, primary and specialty care providers who would be interested in learning about eConsult for pain management. So within this deck here, we have the link. I'll make sure that it's sent to you via chat. So if you are interested in signing up yourself, your specialty partners or your teams, this is open to anyone who'd like to receive free CME for pain management for eConsult. This is July 22nd, 12 to 1 p.m. Thanks for sharing this with your contacts. And we also wanted to get a save the date out to you. We've been communicating our November meeting. We actually shifted the day a little bit earlier. So please do mark your calendar for November 2nd. This will be in Sacramento. We know a lot of you are not in Northern California, so we're going to offer a hybrid meeting this year. So those of you who can join us in Northern California, wonderful. If you would like to join us from wherever you may be sitting, we'll do this virtually. It'll be a fun hybrid experience to be able to meet you all in person again. We've had such a great time being able to get to know so many of you over 7 years. We've had 7 of these meetings now. And we look forward to being able to see each other face to face as we come out of what was a very hard year. So with this, we want to thank our sponsors, Anthem Blue Cross, Arista MD, Safety Net Connect, ConfirmEd, IHP, Rubicon MD, WISE, who help us to make this meeting take place and who give us the support that we need to work on these policy issues that we are tackling as part of growing eConsult use. And also we do want to thank California Healthcare Foundation, who provides the support for our eConsult work group. So thank you, CHCF, too. If you want to learn more about sponsorship, you are welcome to contact me, and you'll get a save the date and an actual formal invite to our November 2nd meeting very soon. A couple of other news items. You all, if you're on my mailing list, thanks for your patience in getting lots of emails from me and our Blue Path team. We send a monthly newsletter. What this includes is recent publications around eConsult. So these are housed on our eConsultWorkgroup.com website. But we love to see that eConsult news is growing. We see publications every month that bring up recent issues, and we like to share the most recent publications we can find with you. So this one came out of New York. Great to hear that there are examples of success in New York too. We focus a lot on rural, and this is talking about a large urban safety net system. And this is in your inbox. You can learn more about this in our June eConsult news highlights. And if you are new to our group, eConsultWorkgroup.com, as I mentioned, has this research in addition to best practices and our playbook of examples of programs from across the country. Many of you who are on the call today have shared those examples with us to put this playbook together. So thanks for your contributions. If you have stories that you'd like to share with us, successes about your programs, they don't have to be published peer-reviewed data. If you have a story to tell of how you are getting to achieve traction for eConsult, we'd love to hear from you. So thank you so much for your time today. And with that, I will wrap up, and we hope to see you in our next eConsult work group call, which will be in July. Thanks for your time today.
Thank you. Thanks, Libby.
Thank you, Libby. Thanks so much.